Namaskar. This is Dr. Harshvardhan Puri. I am a senior consultant thoracic and lung transplant surgeon from Medanta, the Medicity, Gurugram. And today, what we are talking is a very pertinent topic. Should be discussed in detail, very close to my heart, and all the panelists present here. We will be talking about low cost VATs. So, a disclaimer is that we are not going to talk about the details of VATs, how VATs is done, and all those stuff. We will be particularly talking about low cost VATs. It's very important in this country where most of the diseases of the thorax are a lower socioeconomic status cup of tea. So, how can we reduce the cost of the most important surgery in like VATs? So, we'll be talking about it. Our panel consists of great people like Dr. Bharat is there. He is the director of Shwas Chest Hospital in Nanded. And as he has told me, this is the smallest district in India doing VAT surgery in a corporate private sector in his own capacity. Then we have Dr. Dinesh, who is head of Saint Philomena's Hospital, Bengaluru. He is amongst us a learned man. His philanthropy knows no limits. I know that. And we have Dr. Himani. He is senior consultant thoracic anesthetist with us. We are fortunate enough to have her in our team. She will be talking about anesthesia part. And we have the ACE thoracic surgeon from Yashoda Hospital, Dr. Manjunath, who will be presenting his views on the thoracic surgical part. And Dr. Yogesh Jain, who is the consultant in Maharaja Mahavir Hospital in Ranchi. He'll be presenting his views on the pre-operative evaluation and how to select patients for these kind of VATs. So we'll be running in 3 presentations. First presentations will be by Dr. Yogesh. Then we have a presentation by Dr. Manjunath, and then we'll have a presentation from Dr. Himani. So we'll start with the presentations. After the presentations, we'll start by a question answer sessions. And any of the audience would like to put his or her question can put it in the chat box, and I'll be happy to let our panelists answer these questions. So let's start with the Dr. Yogesh's presentation.
Thank you, Harshvardhan sir, for introducing the topic so well. Thank you, CCI, for making me part of this webinar. I'll be briefly discussing on pre-operative evaluation before thoracic surgery or VATS. So we all know VATS is a minimally invasive thoracic surgery that does not use a formal thoracotomy incision. Shorter operating time is there, less post-operative morbidity, and hence earlier return to normal activities. VATS is principally employed in the management of pulmonary, mediastinal, and pleural pathology. So before going into the pre-operative evaluation, we must know the indications for which we refer a patient for VATS. So we have few diagnostic and few therapeutic indications. In the diagnostic pool, we have mediastinal lymph node biopsy, pleuroscopy with or without pleural biopsy, tissue or lymph node biopsy for lung cancer, chest wall biopsy, and cancer staging. And then we have a long list of therapeutic indications. From a pulmonologist point of view, we know that the most common is the pulmonary resection, which is most commonly done for lung cancer, lobectomy, segmentectomy, and wedge resection. Other than that, pulmonary bleb and bulla resection, we use it for, we refer patients for pleural drainage, example for pneumothorax, hemothorax, and empyema, pericardial effusion drainage, mechanical and chemical pleurodesis, excision or biopsy of mediastinal masses, thoracic duct ligation, sympathectomy, chest wall tumor resection, thoracoscopic laminectomy, spinal abscess drainage, esophagectomy, esophageal cyst removal, hiatal hernia, diaphragmatic procedures, chest trauma, diaphragmatic injuries, and epicardial lead placement for pacemakers. We need to know the indications because the pre-operative workup will vary from case to case. For a case of pulmonary resection, we will have to know the pre as well as the post-operative lung functions, whereas for pleural drainage procedures, advanced CPET or lung functions assessment may not be required. So also we should know about the contraindications. That is when we can actually decide whether the patient is fit for VATS or not. Then the absolute contraindications include inability to tolerate single lung isolation ventilation. So in VATS, unlike thoracoscopy, we will be doing single lung ventilation. We use a double lumen ET tube and then ventilate the single lung. Intraluminal mask will not allow us to put a ET tube of double lumen. Severe adhesions in the pleural space, hemodynamic instability, and prior TARC pleurodesis. These are absolute contraindications for VATS surgery. In the relative list, we have previous thoracotomies, prior radiation for thoracic malignancy, severe hypoxia, severe chronic obstructive pulmonary disease, severe pulmonary hypertension, and coagulopathy. So in the pre-operative evaluation, it is very essential for optimal surgical outcome of the patient. Thorough assessment of cardiac and respiratory function is essential. It includes the ASA physical status, spirometry, plethysmography, DLCO, CT imaging, CPET, VQ scan, and other tests. Evaluation of lung mechanics, pulmonary lung mechanics using PFT, pulmonary parenchymal function using DLCO, 6-minute walk test, and cardiopulmonary reserve, which can be done with CPET. It is a 3-legged stool assessment of respiratory system. So just the ASA classification, I told about ASA, which is more used by the anesthesia people, that is having grade 1 to 6. So in the spirometry, the most important one is the FEV1. FEV1 has the most predictive value for the ability to tolerate a resection. In general, if the patient has a FEV1 of more than 2 liters, he should be able to tolerate any resection. Whereas if it is around 1.5 liters, he should be able to tolerate lobectomy. Spirometry and FEV1 values are predictive for post-operative complications also. For example, if the pre-operative FEV1 is less than or equal to 60 and DLCO is less than 50, and if the post-operative FEV1 or DLCO is 50 or less, then there are more chances of pulmonary complications and prolonged hospital stay in the patient. So for calculating the post-operative FEV1, we have two methods. One is the anatomic method. We all know there are 19 bronchopulmonary segments in both the lungs, that's 10 and 9. And the number of segments which are going to be removed, with the help of that, we can calculate the post-operative FEV1. And by the perfusion method, if we do a quantitative ventilation perfusion scan, we can calculate post-operative FEV1, which is more accurate than the anatomic method. So spirometric indices like FEV1, MVV, forced vital capacity, residual volume, /TLC ratio provides insights into respiratory functions. And FEV1 greater than 60% indicates potential tolerance for anatomic lobe resection, and an FEV1 of less than 30% suggests post-operative ventilator or supplemental oxygen dependence. In FEV1 less than 60%, if there is marginal reports of PFT and we still want to take the patient for VATS, if it is essential, we can go for a ventilation perfusion scan, which will help to calculate a post-operative FEV1. If any value around 35-40 we get, it suggests adequate post-operative pulmonary reserve. Then, when the PFTs are marginal, quantitative VQ scan may contribute useful information. It helps in calculating post-operative values more accurately. We had two methods, that is anatomic method and the perfusion method. So this is more accurate, most commonly used when the estimated post-operative values for either FEV1 or DLCO is less than 40%. So additional testing like cardiopulmonary exercise testing with measurements of VO2 max is helpful. So in the cases of marginal PFTs, we have to do these advanced testing. Not all VATS cases will require VQ scanning or CPET. So it is a tabulated form of what we have talked till now. That is, if a patient is requiring lung resection for any carcinoma or other things, then cardiac risk assessment should be done. And if the post-operative predicted FEV1 and DLCO is more than 60%, then it's a low risk VATS But if it is between 30 to 60 or less than 30, then we have to go for the assessment of the functional capacity by 6-minute walk test and stair climb test. If it is normal, then resection up to pneumonectomy can be considered. But if it is abnormal, then we will need to do a CPET test and calculate VO2 max. Based on that, we can classify as low risk, moderate risk, and high risk. In high risk, we should go for a sublobar resection, non-operative modalities, or other modalities. So in the pre-operative evaluation, like with any other surgical procedure, we need to see the blood counts for polycythemia or infection. We need to do all the routine blood investigations and viral markers. Chest X-ray and CT scan provide anatomical details for surgical planning. ABGs identify patients at risk for post-operative complications. A partial pressure of CO2 of more than 50 and PO2 of less than 60 indicates vulnerability. Thorough cardiac risk assessment, ECG and echocardiogram should be done. Additional testing such as PET scan and MRI are ordered on case-to-case basis. Optimization strategies may include smoking cessation, addressing infections, and pulmonary rehabilitation to enhance surgical outcomes. Thank you.
Good evening, everyone. I'm Dr. Manjunath, thoracic surgeon at Yashoda Hospitals, Hyderabad. I actually want to first thank CCI for bringing up this interesting topic of low-cost VATS. In a country like India, where only 10% of the population actually can afford a good health care, it's important that we address such an issue. And in fact, why we talk about VATS being expensive, the first thing is the kind of disease we have. We need an extensive evaluation in the preoperative period. You need to get a CT scan done, a PFT done, a cardiopulmonary exercise test then if needed, PET scan done, a lot of things, bronchoscopies, everything. So the pre-op investigation itself is very high in a thoracic case. Not like a gallbladder or a hernia surgery where there's diagnosis made on a clinical examination, just on an ultrasound, you know that there's a gallbladder, you go get it removed. It doesn't happen that way. Whenever you put a patient for a lung surgery or a thoracic surgery, you have to extensively evaluate them. That itself will increase the cost of the patient. The other important thing we have to understand here is our patients are, one, the infective component is very high. There's a lot of malnutrition. You have to optimize them better. You have to make them get them in a better shape before you actually put them under the knife. So the preoperative optimization also takes a lot of burden on the family and the person in terms of finances. Next thing is the intraoperative. These are very challenging cases. When you talk about VATS, we do like single port or dual port VATS. The cost is high because the duration of the surgery is longer. There are more number of consumables used. Since the duration of surgery is longer, the number of anesthetic agents which are used are longer. You have to have expensive instrumentation. You have to get the right instruments to do the right procedure. So all that will add to the cost of the surgery. And when you talk about lobectomy, for example, if you do a VATS lobectomy, you have to use a lot of consumables in terms of staplers. That itself will actually increase the cost by a significant amount. And when you do a surgery, it's not that doesn't end here, because patients are like, for example, if you do a pneumonectomy, patient is on one lung. Okay, he might need a ventilator in the post-op period. He might be in the ICU for a longer period. He might need a longer course of antibiotics, and he might need a higher antibiotics. So the ones which are very expensive. So along with that, it's not just going to be in the ICU. He's going to stay in the ward also for some time. So all this will add to a lot of cost to the patient. So when we talk about all this, the first thing we think about is, okay, if I have to set up a hospital where I have to do a low-cost VATS, or any VATS for that sake, what is the basic anesthetic and surgical requirement? Let's discuss about that. The first thing is, how frequently are you able to do the procedure? Because once you're doing a good number of cases, you should have the available number of various sizes DLTs, because not one size fits all here. This one thing we should remember here, because for the height of the patient, the size of the DLTs varies, and you cannot just put something and then expect the lung to collapse, because for the surgery, the basic minimum requirement for any thoracic surgery is one lung isolation. So without that, your surgeries will be very difficult. There'll be more trauma to the lung, more complications. So first thing is you ensure that you have various size DLTs. The next thing is, once you place a DLT, you should ensure that the DLT is placed well. So an ultra thin bronchoscope is of great value, but unfortunately it comes with a very high cost and less yield. So we have to be very wary to ask a small hospital to buy it. In fact, many of the corporate hospitals don't have it. The previous hospital I was working, they didn't have an ultra thin bronchoscope. So we used to manage with other modifications. Other thing which is very important, which we generally don't address as physicians, as a surgeons also, is how good is the OT table. Because I have operated in centers where we had trouble because of the OT table itself, because you don't have a battery adjusted table, you don't have a brake. And these things, thoracic surgeries are difficult ones. Already there is a difficult scenario at hand. You don't want to complicate more by compromising on smaller things like this. Then the first and the most important among all of this is the endovision system. You cannot do, like in VATS, your eyes are everything, okay? Like you have to see everything and your hands will follow your eyes. So if you don't have an endovision system, which is great, you're going to suffer a lot, because the moment there is some bleeding, you will lose the vision. I've seen systems, even with the best of the best companies, coming up with poor systems, because the contrast when the bleed happens and the other time is very different. Because the moment there's small bleeding, your vision is lost, and the total field, what you want to see, is absolutely marred, and you don't see anything. So you have to be very careful in ensuring that you have a good endovision system, even in a small center or a big center. That should be the same. You should have adequate ETCO2 and ETCO2 monitoring, and you should have access to EBG, because intraoperative EBG is very important in thoracic surgery. Sometimes I can get away without doing an arterial blood pressure monitoring, but I would prefer it to have it, because slight fluctuation, you'll understand quickly. Sometimes you have a bleed. By the time the non-invasive blood pressure monitor picks it up, you're going to lose a lot of blood. So you have to be very careful in these things. And you should have a good blood bank. And also you should have some training to the staff, which is the basic training which should be done for any VATS procedure, that they should have it in their center. So what I found it very interesting was when I started working in some smaller centers, I understood that if you don't have a bronchoscope, what you do is you use a CM, because most hospitals which are running successfully will have an orthopedic backup. They have an orthopedic setup. So the moment they have an orthopedic setup, they have CMs. So it's easy for you to use a CM and locate the double lumen tube. Here you can see there's a line here. This is going directly to the left. You know that the tube has gone into the left main bronchus, and you're sure that the plug is isolated. To confirm it's gone into the left side, you just place a sponge holder so that you know that this is the right side and the tube is going to the left side. So this is very simple. This is a very effective way of finding out the double lumen position. And I'm telling you, the accuracy rates are amazing, because you get a very appropriate isolation after using this technique. Other alternatives which I use is, for example, if a hospital is already having a very good bronchoscopy, they have a good endovision system, take a 10 mm camera, buy a 10 mm rigid thoracoscopy and use it. Don't do too much investment. It's not going to help you, because you're going to use the same camera. Then for arterial monitoring, we use normal IV catheters, which is helpful. Double lumens are something which you should be careful of, because the bulb is very sensitive. If the bulb is broken or there's some small damage, also you'll have a lot of problems. I prefer using a new one, but if you don't have an alternative, you have an old ETO one, I don't mind using it unless the bulb is intact. So that's all about the anesthetic requirements in peripheral centers. Surgical requirements, there are some negotiable and some non-negotiable. For example, the sterility of the OT, the instruments, the scope, these are non-negotiable. You have to have a thorough, sterile OT and instruments. Why I emphasize more is, we have many centers where they're doing bronchoscopies and medical thoracoscopies, and they expect us to do VATS in the same setup. It's not a good thing to do, because, for example, you want to save money. You're talking about low-cost VATS here. You put a patient on an infection, or you subject the patient to an OT in such a setup where the sterility is not good, and you have a very bad bug hitting him. Patient is going to spend a lot of more money. It's going to be like 4 times more money than what he actually would do without in a sterile setup. So one has to be very careful before doing that. So these are non-negotiables. The other thing which is non-negotiable is, you don't have the set of open instruments. I have been called to hospitals where they said, okay, you do the surgery. But then when I asked them, do we have an open set? They say, no, we don't have it. I thought you would be doing VATS. It's not like that. You have a bad day or you have a difficult case, you have to do open surgery. You cannot just call and say, okay, I don't have an open set of instruments. So that is something which is non-negotiable. Some things which are negotiable are, okay, there is a certain set of sutures which are available, which are not available. We can make some arrangement in that. We can absorb, we can change a bit and do it. Energy devices, again, if you have a good monopolar and a hook, most of my work is done. okay, we don't need advanced instrumentation all the time. We don't need advanced harmonic and ligoshows all the time. That's a little negotiable. But the first 4 points are really non-negotiable. And then when we think of all this, the first and most important thing is how can we reduce the cost of the surgery before the patient comes to me? For example, if a patient has been referred to me early, for example, if he's referred to me in stage 2, for example, let's talk about decortication alone. If a patient has come to me in the stage 2 or early stage 3, patient's surgery is much less complex. You have a thinner peel. The dissection is more complete. The lung expansion is better. The air leak is lesser, and then the patient goes home earlier. The whole sequence of events is different, and okay, this is going to be how it is. The moment the duration is longer, for example, if you have a very thick peel, you have a fibrotic lung. Because, for example, if the patient is left alone for 6 months and then he comes to me for surgery, unlikely that it's going to be a smooth course because you have a very thick peel, you have a very small lung. You have to ensure that you do all the decortication and also ensure that there's no air leak. Despite that, you'll have some peripheral air leak, which has to be managed in the post-operative period. So it will take longer time for him to heal. So this is one of the most important things in terms of empymas and how they are managed everywhere. So one has to understand that the earlier referral is the best one. And we all feel like, okay, this is my patient, let me treat it my way. It's not like that. The patient is none. Okay, the patient is only for their family. And we have to understand that whatever best is for the patient, we have to do it at that time. Then when you look at the lung conditions, for example, if a patient is having recurrent hemoptysis, he has an episode of massive hemoptysis. Okay, maybe BAE may be a transient episode, a transient treatment. But the thing is, you're incurring him a cost. That cost is not small. And then it's like 1/4 of a surgery. So if he does 2-3 episodes of BAE and then it fails, he is going to pay 1.5 times more than what he was supposed to pay earlier. So one has to understand that. So that there is a lot of hypertrophic vessels. Why do you put him to BAE? Just put him to surgery. And the other thing is, when we did a study at AIIMS, then that showed that, okay, it's not just the bronchial arteries which are hypertrophied in aspergillomas. You have the multiple collaterals which are hypertrophied. So no point in just doing a bronchial artery embolization. So patient is going to recur with something else. He's going to still have hemoptysis even after embolization of the bronchial arteries. So that is one of the things I want to talk about. And then the longer the patient is in a primary care center or a secondary care center, the more antibiotics are being given. We see patients who have received practically everything, and then they come to us, and then we are trying to figure out what exactly do we give now, because she's received already practically everything in the last 1.5 months. So you have more antibiotic resistance, and you have a longer hospital stay just because your antibiotics don't work, your leak doesn't settle quickly because you have longer duration of disease. So again, I just want to emphasize on one more thing, that is how a bullous lung disease, pleurodesis may negatively impact the patient. I'll show you videos also for that. One thing in our center we do routinely is we have a very good coordination, and there's some understanding that, okay, if this patient, if a patient is subjected to a medical thoracoscopy, we know that, okay, there is some loculi and there's some adhesions, and then the overall lung is looking okay. We subject them to medical thoracoscopy, and if there are anything like this, for example, if there's a thick septa, if there are multiple loculations, if there is pleural thickening, too much of debris, if the patient is obese, we don't think too much. We put them on the table and convert to VATS. So, if a patient has been converted from medical thoracoscopy to VATS, it's just to make life easy for the patient, as well as reduce the cost to a significant amount, because you're reducing the number of ICU days, number of hospital days, and then the disease-associated quality of life is also lost. So one has to take into consideration that in today's era, people are ready to spend money, but the only thing they want is they want to get back to their work early because they want to earn back the money. So it's easier for us to do it at the same setting, discharge them early, and then make them more productive. I think that is one of the most ideal scenarios in our setting. So there are a few examples. For example, this is a simple effusion. I don't want to put my VATS in this case. I will just ask my pulmonology colleagues to do a medical thoracoscopy and see how it is. For example, if this is a condition where there are multiloculated effusion, I would go for a VATS directly. So, and in fact, we have had good relationship with our pulmonologist, and so we generally get good referrals at an early stage where things can be sorted out. For example, this case, we subjected to the first one I showed you. This was a medical thoracoscopy. We know, okay, there is a lot of sagograin. This is tuberculosis. There is effusion. And then the best part is the lung is fine. You don't have to do a decortication. So all you do is you just take out all the fluid, take a biopsy, and then confirm the diagnosis and finish. Put them on ATT. You don't have to do anything. So this is an early empyema where there's a lot of debris. Okay, you know these patients will need decortication. No point in lingering around, adding streptokinase. Maybe helpful if the patient is sick, but if a patient is young, fit, why don't we give a chance for his lung to expand fully? See, the cost is not just about the hospital. The cost is also about how he's going to live his life fully or not. If his quality associated life index comes down, if he's not living a good quality of life, if he's having some impairment of his life, then the cost of the whole disease is much more than what we think. Again, these are early cases where you see that the previous one was having a lot of debris, but minimal pleural thickening. This one had pleural thickening, but the pleural thickening was still fine. And then, see, it makes my life easy as well as the patient's life easy because the lung expands quicker. See, the peel is coming out easily without much fuss. And then once you do that, you know that, okay, the patient's air leak is also, even if it's a minimum air leak, it's going to settle down because the lung is fully expanding. So this is the kind of scenario which we would prefer. And this is one of the important ways to reduce cost. The moment the pleural thickening increases, this is a simple empyema. If you make it complicated one, obviously the pleural thickening will not be easy to yield. You'll have more air leaks and prolonged hospital stay, prolonged ICU stay, and everything. Now, another common scenario what we see is a bullous lung disease. For example, this is a giant bulla here. You know, this is a massive bulla. But if there are no previous interventions, this is pristine. The lung is pristine. The chest cavity is absolutely great to go. You have minimal dissection to do to get the bulla out. So you don't have to struggle really. So for example, this is the bulla. There are minimal adhesions. The moment you know there are no adhesions, you find the stalk and then you divide the stalk and that's it. You're done. You get the bulla out and then that's it. So patient goes home in 2 days. Okay. So this is a very good example where a previous fluoridesis or a previous intervention, if it's not done, how it happens. Like this is how it is like the lung fully gets expanded and in 2 days patient goes home. Again, this is another case where there's no previous pleural intervention. You have a apical bulla that's taken care and then in 2 days patient goes home. Very simple. But the other scenario is where you have done a fluoridesis for an already existing bulla. For example, this is a case. This guy had a bulla for quite some time. He underwent 2 times fluoridesis, once betadine and once talc. You can see the talc powder having all the effect here. And look at the reaction between the pleura and the lung. It's very, very bad. It's like the lung is totally stuck up everywhere. Now, the moment I go in, it's not pleasant for me because I'm not able to find a good plane between the lung and the pleura. The other point is, if I leave it at this point, he's going to have a massive air leak. It's not going to settle down anytime sooner because the lung is not fully expanded. Other thing is there's a bulla which already is ruptured. So you have to take care of that one also. So it's a very, very complex scenario for a surgeon, especially, for example, if a patient has come with pneumothorax. If first thing is, I don't like this confirmation of a pneumothorax by a CT scan. It doesn't give any extra information. You just put a chest tube, let the lung expand, and then get a CT scan done and see whether it's primary or secondary. If it's primary, well and good, we wait. You manage conservatively and hope that he doesn't recur. If there's a secondary, if there's a bulla already, that means he's going to recur anyways. So why don't we just subject these patients to an early bullectomy? Bullectomy per se is a very simple procedure. Whether it's small, giant, doesn't matter. Size of it doesn't matter. It is just a very simple procedure. But the moment you add fluoridesis, it becomes like this. See, this is more like a first I'm trying to do a decortication, then followed by a bullectomy. So the effect of fluoridesis has to be very, very important, has to be understood well so that we don't subject the patients for fluoridesis unless it's really indicated. So that's about 2 very common conditions. Now I want to just compare between 2 things. One is a corporate setup and a peripheral setup, how things can be different. For example, we get more referrals for complicated effusions early because the moment the patient stays in the ICU for 1 or 2 days, we know we have to find a solution this way or that. So a surgeon is involved much earlier. In a peripheral setup, this event actually happens less often because there is a chance that, okay, he will, there is a tendency to think that, okay, he'll be better with medications. We'll keep him in longer in the ICU. So the ICU stay becomes more in case of in peripheral centers. And there is an earlier refer and rest ICU stage, because the moment we diagnose, we treat him, and then we try to shift him out of the ICU the next day itself. So this is one of the most important referral change, which the kind of referral bias or referral change we can see in this in both the centers, whether it's a corporate or a peripheral center. When you compare again between corporate and peripheral center, there is one more change, that is how we can change the consumables. So for example, in a corporate setup, most of the things are chargeable. Anyone who has worked in a corporate will have a fair idea that most of the things what we use are chargeable, and it is according to the norms of the hospital, and the surgeon doesn't have much say. The double, if you use a double lumen, it is chargeable. In a smaller setup, you can use reusable ones. HD monitor, everything is charged. You have your instruments are charged, your arterial monitoring machine is charged, everything is charged. Then you have the stapler. In case of, if you do the good advantage of doing in a corporate, if you have a good volume, you'll have your kind of your own inventory where you have your surplus of staplers where you can use for someone who's very poor. But in a smaller setup, the advantage will be the cost will be much shorter when compared to the corporate hospitals in terms of direct consumable buying and all that. Energy devices, again, we have inventories, we have own stock, so we don't bother much about the energy devices or the staplers. We have a certain set of stuff we can make it and use it. The controllables are in a smaller setup, they can be controlled. You don't have to charge. Many times we don't get an energy device, an advanced energy device in smaller setup. That's a disadvantage of it. And endo-GI gun, we all know. Most of the surgeons who are here will agree that we all use to a certain extent, reuse them till they give up on us. So that is one of the things we use, these endo-GI staplers, which very commonly we use them. So it's reusable in both the centers, but in some hospitals they do charge, despite them being the reusable ones. So coming to the last few slides, first thing is how to reduce cost in the corporate hospitals. The best thing is fast track a surgery. Admit the patient on the day of surgery. No need of ICU stay if a VATS is done. Generally, I don't keep a patient unless there is severe acidosis or there's a requirement of NORAD, or the patient is having the requirement of BiPAP or something. Unless then, I don't keep them in the ICU. I have a very strict protocol not to send them to the ICU and send them to the room directly. And I tell the relatives also that you can have dinner with them most of the times, because that's how the patients are when they finish a VATS surgery. I don't put a center line unless it's like a sleeve resection or a very difficult upper lobe one which is stuck up to the chest. That's the only indication where I put a center line. We mobilize the patients very early. The most important, and I think that the game changer is how to minimize the air leaks in the post-operative period. Whatever you do in the surgery reflects in the post-operative period. If your air leak is less, that means you have done a great job. Because the moment the air leak stops, the tube goes out and then the patient goes home. So that's one of the most important strategies, how to reduce the cost of the patient. Because the longer the air leak, the longer the patient is going to stay in your hospital. So the other way of reducing cost is in a corporate hospital is doing a daycare surgery. One of the important things is now what we are doing is a daycare sympathectomy. It is a non-intubated one. So we do a lot of procedures for sympathectomy. And the best part is patient comes in the morning and by lunchtime he's gone home. And generally the trend is I admit them on Fridays and Saturdays, operate them on weekends, and then Mondays they start working. So by that, they're not only reducing the cost of hospital cost, but also reducing the number of days lost in work due to the procedure itself. So that's one of the ways. Other things I do daycare are lymph node biopsies. Sometimes you have these large paratic lymph nodes not accessible by EBUS. I get referral for that, and I do them. And then sometimes you do lung biopsies. A very rare component, but sometimes we do get it. And very rarely I do these simple bullectomies where patient is really unaffordable. You do a bullectomy and send him with the ICD. I just prefer to send him with an ICD. I don't remove the ICDs immediately. I send them with an ICD. Similarly with a wedge resection, small nodule, you know that it's going to be nothing. You do a wedge resection, just keep him for a few hours in the hospital and then send him with an ICD and call him after a few days for ICD removal. These are some of the things which I do daycare. But I have to tell you that there's still a lot of scope for improvement in daycare VATS, because it's not easy to send an patient with ICD. You have to be very careful if the tube comes out in the night or there's a kink or this thing. It's going to be a little bit of headache. Since I have a stronger team to manage things, so I'm okay sending a patient with a tube home. So the one last thing I want to talk about is when not to do in a smaller setup. The thing is, if there is extremes of age, for example, if the patient is too old or too young, we don't do it. It's because you don't have the right kind of equipment to manage the patient. You don't have the right backup. You don't have a right backup of ICU, pediatric ICU, and all that. You don't have a coronary ICU to manage a MI or even a stroke or anything. So these are the kind of cases which better to be done in a corporate center where you have multi-specialty departments. Other thing is there's a multiple comorbidity. You don't do them because you don't know what. For example, if a patient has a creatinine of 1.5, 1.6, you subject them to surgery. If they have bleeding, you don't want to end up sending the patient for dialysis to another center. So you don't do that. A long-standing disease, again, a big no for me to do it in a smaller center. If there's a previous intervention, for example, I showed you a video of pleurodesis being done. It's a bad thing to do in a smaller center because you're going to bleed more. You're going to have more problems. You're already taken up something which is buzzed up by others. You have to be way more careful in that scenario. And especially in redo cases, I just tell them that this is not a scenario where we should do in a smaller centers. They should be brought up to a tertiary care center and do there. The last point, which is very important, is whenever you want to start a VATS program, you also have to have a team which is ready to troubleshoot your endovision system and all that. So if the hospital is not doing a regular laparoscopic work, that means they have no understanding how does the camera system works. So you go and stand there and then you realize they've given some camera which is not even visible, and then say, no, you continue with what you want. So this has happened to me, and I'll be very careful now. I ask them whether your regular laparoscopy work is going on or not. That is something which is basic. If they're doing it, then I feel, okay, that system can still be used. And earlier I used to be more daring. I used to do more cases outside. Now I don't do it anymore because I kind of feel like, okay, the safety of the patient and the surgeon is more important. So I try to stay in my hospital and do most of my cases. So this is one of the things. And lastly, I want to put up this slide. I want to just say, everyone, that especially in pleural disease, generally what the pulmonologist feels is, okay, this surgeon is a 12th man. Okay, we can do everything now. We do a pleural biopsy, we do decortication also, we do additional everything. So it's not like that. I mean, you can do it. It's not the question of who do it, you do it or me do it. It's not like that. You consider me a 12th man, it's fine. But we always feel that we are the impact factor. Thank you.
Good evening, everyone. First of all, I'd like to thank CCI for giving me this wonderful opportunity. As Dr. Bharat and Dr. Manjunath has already discussed in detail about the pre-operative evaluation and the surgical aspects of VATS. So I'll be building upon their discussions by focusing on the critical aspects of anesthesia and VATS. So why it's so special? Because of the pre-operative evaluation that has already been discussed. The next important thing is the single lung ventilation or the one lung ventilation. It is the separation of two lungs and each lung functioning independent by the preparation of the airway. One lung ventilation provides protection of the healthy lung from the infected or the bleeding one, diversion of the ventilation from damaged airway, and improved surgical exposure, which is required in the VATS. So, but one lung ventilation is associated with a lot of physiological changes and may lead to development of hypoxemia in the surgery. So most of the VATS procedures are done in the lateral decubitus position. In this position, the perfusion is more on the dependent lung and ventilation is better on the non-dependent lung. But this will lead to VQ mismatch. By selectively ventilating the dependent lung, we are improving the ventilation in the dependent lung along with the perfusion. But still some fraction of the cardiac output is still going to the non-dependent lung, and which will develop the shunt fraction. To prevent that, there is a mechanism called hypoxic pulmonary vasoconstriction, which develops around 20 to 30 minutes after the development of the one lung ventilation. As soon as the alveolar oxygen pressures decline, it leads to the vasoconstriction of the pulmonary circulation and diverting the part of the pulmonary circulation to the dependent lung, therefore improving the VQ mismatching. So the next important thing is to follow the lung protective ventilation of the dependent lung. We have to follow the low tidal volume, 4 to 6 ml per kg of the ideal body weight, moderate PEEP of 5 to 8, and we have to limit the pressures of peak pressures less than 35 and plateau pressures of less than 30 to prevent the development of ALI and AIDS post-surgery. Now, how to achieve one lung ventilation? We have double lumen tubes, we have bronchial blockers, we have single lumen ET tubes. DLTs are the gold standard. So these are the DLTs. We have right-sided DLTs and we have the left-sided DLTs. So the left side, it has a tracheal lumen and the bronchial lumen and the two cuffs. The right side is different from the left side because it has a separate slot on the bronchial cuff to match with the right upper lobe. So this is how the DLT looks after insertion. This is in the left mainstem bronchus. This is in the right mainstem bronchus with the slot in the bronchial cuff matching with the right upper lobe. Now, how do we select the DLT? So left DLT is usually preferred. Right DLT is only put when there is a left pneumonectomy, there is a left sleeve bronchial resection, and there is a distorted anatomy of the left main bronchus. So how do we select the size of the DLT? Based on the gender and the height, and based on the measured mainstem bronchial diameter as in the CT scans of the patient. So this is regarding the gender and the height. How do we calculate the size of the DLT? And this is regarding the bronchial diameter. How do we decide the size of the DLTs? So this is how do we see the well-positioned left DLT by bronchoscopy. First, we put the bronchoscope in the tracheal lumen, and that is how we see. So this is the right mainstem bronchus. This is the right upper lobe. This is the far away. You can see the intermedius. And this is the tube going into the left main bronchus. Then next we put the bronchoscope into the bronchial lumen to see whether the bronchial end is not impinging on the secondary carina. We can also put a DLT through a tracheostomy stoma as well. DLT have its limitation when there are huge mediastinal masses compressing the airway, like in this patient who have difficult airways, extreme tracheal deviation, or children with smaller airways. DLTs cannot be used. So there we have option of bronchial blockers. Most common are the Arndt wire guided blocker and the Cohen tip deflecting blocker. It can be put intraluminary through the ETT tube, and it can be put outside the endotracheal tube. So this is the video showing the extraluminal bronchial blocker placed in a child. Single lumen endobronchial tubes are rarely used, difficult to achieve optimal position, and used only in emergency when nothing is available. So Arjuga, tube over the tube, smaller tube and the bigger tube, they can be combined together to increase the length of the tube, which can be put to the distal airways. So in case of NED saturation during the surgery, we have to increase the FI to 100%. We have to check the position of the DLT or the blocker with the bronchoscopy, suction the airway if needed, optimize the cardiac output, recruit the ventilated lung by applying the PEEP, CPAP to the non-ventilated lung, or intermittently ventilating both the lung if nothing is happening, or oxygen insufflation to the non-operative lungs. Lastly, the pain management. Pain management, we have multiple options. We have thoracic epidurals. We have various ultrasound guided blocks like ESP, SAP block, PEG block, paravertebral blocks. Usually in VATS, the local infiltration and these ultrasound guided blocks suffice. But if the surgeons say that there are high chances of conversion to open, then epidural blocks can be put. So to conclude, it is an exciting subspecialty. It is full of difficult and challenging airways and a lot of hemodynamic shifts. We need to have adequate preoperative evaluation and effective communication with the surgical team, thorough knowledge about the airway anatomy, and the pain relief, which is the most important factor for the optimal recovery. Thank you.
Excellent presentations by Dr. Yogesh, by Dr. Manjunath, by Dr. Himani. So let's put into perspective. We are talking here about VATS, which is video assisted thoracoscopic or thoracic surgery. And I just want to tell everybody listening to this presentation that VATS is not same as thoracotomy or thoracic surgery. It's a completely different scenario. It's a completely different field. If somebody is trained in open thoracic surgery very well, he may progress to VATS, but most of the surgeons, older surgeons who were CTVS surgeons, were not even trained in laparoscopic surgeries. So it was very difficult for them to venture into the arena of VATS. So I'll start today's discussion by putting one question to Dr. Manjunath, if he's not dropped.
I think he's not there.
Okay. So I think his connection is not okay. So let me ask the first question to Dr. Bharat. Dr. Bharat, you have started and established.
Manjunath sir is.
Dr. Bharat, you tell me, when you have started a VATS unit or a thoracic surgical unit in a very small place like Nanded, what are the difficulties? What are the challenges? And how difficult is it for you to convince a patient for VATS surgery in a small setup at your place?
First of all, thank you, CCI, and thank you, Harsh sir, for this question. Yes, I believe that VATS or the idea or concept of VATS is difficult for doctors themselves to understand, like physicians or even chest physicians working in smaller towns. They have a small taboo or a fear about VATS. So I think explaining the procedure in proper language to the patient and the benefits of the procedure to the patient is very important. And definitely, cost is a challenge in smaller towns when it comes to VATs. But having a proper team and going by step and then choosing your cases wisely, it is very, very important when you are starting doing VATs in smaller towns for a cost limited setting, I feel.
And is it difficult? Like, I'm not talking about decortications here. Suppose you have a large aspergilloma in the right upper lobe. So, how would you convince this patient that, see, I want you to go for surgery here, but it would be done in my center in this low cost? Is it difficult? Is it difficult? Is it really difficult?
It definitely is very difficult. I think for smaller towns, we are talking anywhere in interiors of India. The case you're talking, if there is a aspergilloma, if it is not bleeding, if it is not creating problems to the patient, वो patient आपके पास आएगा ही नहीं. He will not come to you.
Yes,
Once the
he's hemoptizing. He has
yeah.
massive hemoptysis, has one episode, and maybe recurrent
And
hemoptysis then.
then probably you will have to explain to the patient that this is your definitive treatment of choice. This can relieve you of all your misery. But if it may be the first case you are doing at a center, I will not advise you to start
Yes,
doing such cases. There is a
yes,
way that you have to have a team, and then it is just like bronchoscopy. You directly don't go into a rigid bronchoscope and do a central airway. Similarly, with
yes.
VATS, probably as we were discussing in the talk that Manjunath sir was saying, maybe a grade 2 empyema, something more easy is what you start with doing, you're confident in doing, and then slowly build up to such cases, I feel.
So, very important point which has been told by Dr. Bharat is that you have to grade your case according to the center you are doing it. It's not a joke to do a big fleshy upper lobe aspergilloma in a tertiary care in a peripheral center where you don't have backup of blood banks, you don't have better ICUs. If the patient bleeds, the patient is going to just come off there. So be very cautious of, if anybody is starting a VATS program, just graduate from doing small pleural biopsies, early effusions, pleural, maybe lung biopsies, maybe small, these kind of procedures, maybe lymph node biopsies, failed EBUS. These are the cases to be taken as first cases when you start a program of VATS. Now, my question is to Dr. Dinesh. Dr. Dinesh, you are working in a very beautiful city of Bengaluru. Same set of questions. Is it difficult for you to convince people for VATS? And I'm not only talking about VATS. I'm talking about thoracic surgery in general. See, not even 10 to 15% of the people suffering from thoracic disease have access to a thoracic surgeon. Or even for many of the corporate hospitals, many of the cities don't have a good thoracic surgeon at their backup. So when you see a patient in your OPD, you know that this patient requires a thoracic surgical. What is your approach to that patient, Dr. Dinesh? Sir, you can unmute yourself.
Yeah. Good evening, everyone.
Good evening.
A very difficult question to answer, but yes, unfortunately, I'm sure everybody of us are facing the same scenario. Yes, I do get a lot of patients with different etiologies who definitely require thoracic surgeon help. Of course, yes, it is a really difficult task to convince them based on the disease. And also, it's just not the patients themselves, it is also the relatives where we have to really talk to them. And that requires a lot of time. Trust me, it requires a lot of time. Secondly, it also requires to, elicit or, get into their confidence. Otherwise, it is very difficult. And I do have a wonderful team where in the recent past, I've also included a psychiatrist also in my team so that, it evolves them, it helps them understand to get out of the trauma. See, most of the cases we come in hemoptysis, to just calm them down, get the first part of the treatment done, and then convince them for the surgery, explain, sit to them. And I also have the PTs with me, so that helps me a lot and makes my work a little bit more easier. And as you know, the first line of people who talk and then the second line come, they usually, subject
Get convinced.
Yeah. So that does help. But yes, definitely, it is difficult, especially when it comes to costing. And I think Dr. Yogesh and Dr. Manjunath and all that who have spoken expressively and, in detail about how we do the staging. So, quietly also in those 1 or 2 days prior to them getting convinced, if you'll keep doing the other workup so that the hospital stay also doesn't extend, it does make a huge difference. And I also agree with the speakers, who told that, you do send them, if at all it is not a major thing, you do send them home with the ICD. Of course, you need a good team to back you up. Like I do have some respiratory therapists. We run a course and I have an intensive nurse. So I ask them to go meet and see them at least once or twice in a day. And they take their turns. If at all I discharge them or we our team discharge them, they go there, they see there and teach them and ask them to come as and when it is necessary. So that does help. But convincing them is definitely a huge task, especially when it requires the post-op care. Of course, definitely, yes, the post-op care, if at all the patient requires with the comorbid conditions, then it is definitely a difficult task. If at all there are not many comorbid conditions and if at all you're able to extubate, like all the speakers said, on the table, it does make a huge difference. And also choosing the patients, definitely choosing the patients.
Very important.
Keeping in mind their comorbid conditions or any other conditions which has led to this condition, or also what is with the preconditions thing. So, and of course you definitely require a good team, be it an anesthetist, be it the surgeon and the other ancillary people who definitely helps.
Great answer, sir. So whenever I talk to my pulmonology colleagues, they always tell me that if you refer the patient early to a thoracic surgeon, it becomes much easier for them to convince the patient, because you just tell that, okay, my line of treatment ends here. Now the best treatment you can get or the definitive treatment for your disease can be given by a thoracic surgeon. And as I have in Medanta, I have my MDT computers on. My pulmonologist just can give me a video call. I can see the patient sitting in his OPD and just talk about the patient. The patient gets convinced that two senior doctors are concerned about his outcome. That's the way to convince the patient, I think.
Absolutely. Multidisciplinary approach.
Yes.
Assessing or sending the patient and seeing that, they get earliest reference does make a huge difference. Yes, convincing also requires for you to represent or even having your thoracic surgeon in your loop. Telling them, sending the patient them at the earliest. Suppose you say, like I was told, you have so many loculations and, there's no point doing the thing. You'll have to explain to them. And then again, the second person comes and the third person comes. Then the senior doctors explaining to them, they definitely, of course, more often than not, they do get convinced. But of course, if you trickle out, that is not in your thing. But definitely, that is a way of approach. MDA is the way forward, especially if at all you want a good
outcome
of the patients. Yes, definitely, yes.
So the second most pertinent point from today's talk is a multidisciplinary team meeting for all the cases, not only for oncology, for benign cases also should be done. If Dr. Manjunath is back, my next question will. Hi, Manju, how are you?
Fine, sir.
So,
sorry, there was a delay. Really sorry.
We are not able to see your video, Manju. I think there is some issue with that.
Yes, I'm just coming out of the airport, sir. Yeah.
Oh, yo. Okay. So, Manju, my question is just briefly explain to the public who are novice, what is the difference between VATS and thoracotomy?
So, VATS is any surgery which is done with a less than 8 centimeter incision without any rib spreading or rib cutting. So, the idea of VATS is not only just a small incision, but also sparing the chest cavity from being spread or the rib being broken. So this is the main thing. The other thing is you use an endovision system with an advanced instrumentation to do whatever is needed inside the chest without opening up the chest. That is about VATS. So now when we do a thoracotomy, you either we apply a rib spreader to ensure that the vision is proper. So the moment we apply the rib spreader, you cannot call it a VATS. So that's the main difference.
So whenever we make the SS to the thoracic cavity with the help of a open incision, that is thoracotomy, and most of the problems, as you have already told, is because of that rib spreading, not because of the size of the incision. So it doesn't matter whether you make small 3 incisions, you do multiportal VATS or you do uniportal VATS, that's a different thing. But small incisions without rib spreading is VATS, and big incision with lot of rib spreading, maybe breaking the ribs, is thoracotomy. So inviting lot of problems in the post-operative period like chronic pain syndromes and all those stuff. So my next question will be to Dr. Yogesh Jain. Dr. Yogesh, if I may ask a pulmonologist viewpoint, do you think we are all talking about VATS today? Yes, it's a fancy thing. We are doing uniportal VATS now, uniportal robotic surgery. But do you think in a resource-constrained country, India is, having a good thoracic surgeon or a cardiothoracic surgeon who can even do a good open surgery for your patient is as pertinent as doing a VATS? This is my question to Dr. Yogesh.
So, you are saying that we must have a backup of thoracic surgeon in wherever we are doing VATS. My question is, if you are a pulmonologist practicing in Ranchi, so would you like, if I'm a thoracic surgeon and I'm not VATS trained, but I know a good open surgery also. So would you like me to be in your vicinity in a resource-constrained, restricted country like India? Even open surgery is a good enough option for your patients? So as we are talking about, as we are talking about the low-cost VATS here, so with the VATS, we know that the perioperative post-operative morbidity is less, the hospital stay is less, and even, the post-operative pain is less. So if we see VATS, initial cost may be high, the pre-operative evaluation or the VATS instrumentation may be costly. But if we see the post-operative stay of the patient and post-operative complications, which is much lesser in VATS as compared to thoracic surgery. So definitely surgeons will help. We know that if the VATS fail, if the VAT we are not able, we get complicated VATS, and then we have to convert it into open one. But definitely like in our state, where I'm working in Ranchi, there are hardly 2-3 thoracic surgeons. So in a big city like Ranchi is the capital city of Jharkhand, but there are 2-3 surgeons only. So it's not essential. Like if there is a VAT setup, then definitely a backup of surgeon should be there, and who is able to do an open thoracotomy also.
Yes. So my thoracic surgery friends are going to kill me, but I want to quote a latest study, a very big randomized trial which has been done, which shows, Dr. Yogesh, that a difference between a good VATS or a good open surgery done is only 1 day of stay increase in 1 day of stay in the hospital. So my point, Dr. Yogesh, is I had a opportunity of conversing with a very senior thoracic surgeon from US, Dr. Sai Yandamuri. He came to India and worked for around 5 years in India, and he did very tremendous work in Hyderabad. So one day we were conversing in my car, and he told me, in a country like India, where thoracic surgical load is so much, and most of the cities have these big general hospitals, Sarkari hospitals, even if a cardiothoracic surgeon or a thoracic surgeon does a very good open surgery, that would be should and be a boon for it. And as a largest thoracic surgical unit in the country, I still believe that open surgery has got its own benefits. Or in huge tumors, in cranial resections, in lung transplant, lot of surgeries can only be done by open thoracotomy. So if my dear young surgeon friends are listening, doing VATS is a very good thing. But if you have to convert your patient or you have to do an open surgery, don't consider it as your bad day. It will happen as your numbers will increase.
Absolutely.
My next question is to Dr. Bharat. Dr. Bharat, what are the problems in establishing a VATS or thoracic surgical unit in a small city like Nanded, and what are the cost implications of it?
Thank you, sir, for this question. I think the first step is for us pulmonologists to have a team. It starts from there. I don't feel in a smaller center or a smaller town, a single pulmonologist can do that. So we at Shaw's Chest Hospital, we are like-minded, a team of 4 pulmonologists. With our basic work growing, then we thought we could expand. Second is to have a proper IRCU backup and a good cardiothoracic anesthetist to work, because that is must when you are planning even simple VATS.
Yeah.
Then probably we may have, or we will look out in my center, or in my place, we don't have a thoracic surgeon, but we are close to Hyderabad and we could have a good team with Dr. Manjunath. So then, and finally, as I always say, start with the easy cases. So then once, because as you were mentioning, or someone, sir, was mentioning in his talk, that the support staff needs to be well trained with the tower, with the settings, with the equipments. That is very, very important. So when you do little bit easy cases, probably then you can expand. Like now we have done more than 25 cases in last 2 years. So now we are slowly growing. So I feel that is the way to, one step at a time, to grow into VATS.
Great. And what are the roughly the cost implications, if you want to tell the public?
So, no, definitely I can tell. Mine is probably a tier 2, 2.5 to tier 3 city. I will say the district population is around, the city population is around 6 to 7 lakhs and the district population around 30 lakhs. We try to keep it as low as possible. Initially, we also try to give it as a package, including the medicine, but then few complications here and there, then it was, the hospital burden was increasing. Roughly, I would say a VATS procedure for a grade 2 decortication may, along with all anesthesia and all charges, hospital stay, probably will cost our patient around 1.5, including the medicines and everything. That is a rough estimate we give. And as sir was telling very rightly, it is 2-3 people convincing the patient first, and then definitely there are patients who there is a big problem, or for them 1.5 lakh and 3 lakh, the difference is too much. The difference for patients is too much. So we need to understand that and then try to provide them a low cost VATS as far as possible from our end.
Great. So my next question will be to Dr. Himani. Dr. Himani, what is the minimum monitoring you would like if by the way, Dr. Himani is also wife of one of the ace thoracic surgeons we have, Dr. Mohan Venkatesh. You all must be knowing. So all in the family. So what is the minimum monitoring you would require when Dr. Mohan is doing a lobectomy? Minimum.
So, as we all know that we need one lung isolation. So definitely a DLT or a blocker.
Most important.
Yeah, that is the most important thing that we'll need. And in terms of the invasive monitoring, So, in lobectomy, definitely an arterial line, but in other simpler cases, like it is a sympathectomy or talc fluorodesis or maybe a simple wedge or decortications, we tend to avoid arterial lines in our center until unless patient-related factors or patient comorbidities indicate. Then we go for an arterial line. Otherwise, we tend to avoid that also. And we usually go for wide bore cannulas. We don't usually generally go for any central lines in our patients, especially lobectomies or sleeve lobectomies. That we put only on pneumonectomies or any major mediastinal tumors or esophagectomies like that. And we need fiber optic bronchoscope guidance, obviously, to put the tube, to verify the position, and to deal with any problems intraoperatively. For cost cutting, what we usually do, we use that Ambu disposable fiber optic scopes, but we reuse it in at least 4 to 5 patients. So the cost decreases by 1/4. So by that we can decrease the cost. And epidurals, if it is a VATS case, we generally don't put epidurals until unless the surgeon says that there are high chances of converting it to open.
Yes.
So because that epidurals and post-operative PCA pumps, they add a cost to the patient. So that is also generally avoided in the VATS cases. We can simply do infiltrations or just the peripheral nerve blocks can be done for that.
Dr. Himani, a very common question people ask me: if you don't have these ambu scopes and non-disposable scopes, can you clinically also judge whether you have placed the DLT right?
Yes, by auscultation, sir.
Yeah.
We can do that.
Yes, because
But
I've
of course,
seen
that is not the gold standard. Sometimes, there are some tricky situations where we can get stuck. So gold standard is fiber optic, but definitely the centers where we don't have the auscultation is the way.
Mani, when I was working in LRS hospital, unfortunately, they were doing very good amount of thoracic surgery there, but they never had any bronchoscopes or something. So always they used to check by a clinical method and move ahead.
Especially
so
in government setups, that is the issue. We also learned like that only. Yeah.
Yes. So I just want to tell people it's not mandatory for few things to be there in a thoracic surgical setup. Few things are non-negotiable, as Dr. Manju has already told, but few things are negotiable. We can be taken care of. I'll be telling you about the Robin Hood approach also at the in the mid of the conversation when we be having. Dr. Manju, now how can you reduce the cost of VATS surgery? That is the most pertinent question today. How to reduce the cost? See, the level of talks have increased. 4 or 5 years back, we were just talking about how can we do VATS. VATS. Today, we are talking about how can we reduce the cost of VATS. So please put some light.
So one of the things is admitting the patient on the same day. I generally call them on the same day of surgery, admit them, and then prep them in the pre-op and then take them to OR. As we discussed about the anesthetic management, no need of central lines for a straightforward lobectomy unless it's a very bad aspergilloma or a mucor. We don't need a central line. Arterial monitoring, definitely I would need for a lobectomy, not for a bulectomy or a decortication. I would avoid it. And then when we come to the surgical aspect, there are a few things. One is a very, for example, if you're doing a lobectomy, if your bleeding is less, if your air leak is not there in the post-operative period, that itself will reduce a lot of cost for the patient, especially in a corporate center, because you're going to keep the patient in the ward. You're going to keep the patient, you're going to send the patient home early. So that will itself reduce the cost to a greater extent. Now, when we talk about VATS lobectomy, the main cost is about staplers. So one has to understand that the staplers are expensive. Now, how can we reduce the cost of the staplers? One of the things is I mentioned in my talk also that we have an inventory where we try to get some staplers and then use it for patients who cannot afford VATS. For example, if you're doing 10 cases in a month, the 11th case, we have some surplus of staplers which we can use for the 11th patient. For that, you have to do 10 cases. For example, if you don't have the right volume, you'll never be able to do that. If you're doing a good number of volume, then this advantage we can give to 1 or 2 patients in a week or so. So that's where it comes. We cannot come down on the staplers. It's not like purposely I use more staplers or we can come down suddenly doing something else. Whatever we do, it will only increase the cost because if you don't use the staplers for completing the fissure, it's going to leak. And if it leaks, the patient will suffer more, and the cost will automatically be more. So rather than that, I use a stapler extra and then send the patient home with a lesser leak. So and vascular staplers, there is no alternative, sir. As you totally agree with me because there is no alternative. You have to use them. You have to use them. There is no choice with that. So only thing how I can say is you can reduce the ICU stay. If you don't put the patient in the ICU, you send him to the room, and then that itself will reduce the cost. And one more thing about I wanted to add the point when we were discussing about convincing the patient. What I generally tell the patient is, you're going to have dinner with your family if you do a VATS. And if that's the level of confidence I have in sending the patient to the room, patients generally agree. They'll say, okay, the procedure is not as big as we think. So that is one of the easiest way to tell a patient, okay, you undergo VATS, you're going to have dinner with your family. They will say, okay, maybe this is worthwhile taking rather than suffering with all the ailments I have. So I think that's one of the easiest way to convince them.
Great. So thank you for the answer. Dr. Dinesh, coming to your scenario, how would you reduce the cost? The biggest factor in India.
The previous center where I worked, I did create 2 verticals there. One was for complete aseptic thing, and the other one was for the bronchoscopies and medical bronchoscopies as well. But I did that. The reason why I did that was I didn't want any, as you know, there are a few people or a few centers, a few hospitals would want to club with the endoscopies. That is the major problem. And I had to put my foot down where I did create 2 separate rooms, 2 verticals. And I did have a backing of my CTVS team. That is one thing. As Dr. Manjunath said, you will have to make sure that you do not overuse your inventory. Of course, the staples are one thing which nobody can do much about. But of course, with a few cases like this where we can do something about, we can do that. Secondly, again, doing a lot of arterial line or central lines or whatever, I try to do with the EJVs or whatever I can, as and when it is necessary. But if it requires, then there's no point. So we try to save on patient-to-patient basis, wherein we work out with the cost. Of course, I do have a very good team as of now who does support me, be it the anesthetist, be it the anesthetist and the cardiothoracic team. They do support me with this. So that helps me a lot. Secondly, as I said, if at all the patient comes with hemoptysis the first time to your hospital, in the meantime, you work them up for the pre-operative thing itself before you subject them to surgery. Whether they accept or not, that's secondary. We can keep that in mind, but also keep doing this and keep coaxing them to go in for the endoscopy. And like Dr. Manjunath said, get them into your confidence and give them a more confidence, saying that, you will definitely get better, or whatever he said. I mean, that was a wonderful way to actually coax them. You can go back and have your dinner with your family. That is definitely the way forward. Something like in that scenarios, I do talk to them. And that's the reason why I've also got a psychiatrist involved. The reason is it does make a huge difference. And of course, the PROs and all that stuff. So it's a whole lot of a team. It's just not the medical team. It is also the thing. And also, if at all it's your own hospital, it is okay. But if it is not, you will have to take care of your management. I hope you'll understand what I'm trying to say.
Yeah.
So keeping them. And of course, in a center like mine, I do get a lot of cases. So that does help. So it also depends on your workload, the number of cases what we get. So that does help in reducing the cost. That is one of the factors. I'm not saying that is the factor, but that is one of the costs, one of the factor. And secondly, speaking to your referral doctors. Now, suppose I've seen many patients who have come to me, they've gone about just tapping and aspirating, and then they come to you after 2 or 3 months. In fact, today I had 2 cases of such with complete loculations. And what would you do? You definitely have to tell them, this is what it is. They said, sir, we can put in some injection. I said, see, that is not possible as of now. I mean, that's how you'll have to talk to them, give them more confidence, saying that, this you can definitely do. You can do much more better work. You will not have, restrictions post your surgery, and it is just like a daycare thing if there are no complications, so on and so forth. And if at all it's a young patient, you can take them into confidence more rapidly in saying that, since you don't have any major complications, you can be getting out of the hospital. And if the tube comes out in the second or third day, you are definitely out. And definitely, yes, of course, taking care of the air leaks. But putting everything into perspective, you definitely require a lot of support from your team and the others, and trying to, and as I said, using a lot of EJVs. Sometimes I've done, yesterday I did 2-3 thoracoscopies where I did it on the local itself, not on, so that does help. So on the patient-to-patient basis, where you can keep the cost as the same, but work on the verticals and make sure that you can utilize the same amount for the next patient.
Great. That's a great explanation, sir. So, Dr. Bharat, coming to you. If anybody in the audience wants to set up a peripheral center where a VATS surgery can be done, just enumerate the equipment which minimally is required to set up a VATS unit.
Basically,
what is the most essentials?
Most essentials are, first, you should have your basic bronchoscopy thing. You should have your basic bronchoscopy suit, everything which is required if needed to go in. Second, I feel you should have a good IRCU backup with all the settings, all ventilator settings, which are not there generally in smaller towns. Thirdly, before planning in any case, I think you should talk with your surgeon and get the instrument. What happens is pulmonologists are not familiar with those instruments many at the times. We do medical thoracoscopy. So we need to have a team meeting and probably arrange the set of instruments. So when you are doing the procedure, then there will not be any problem. So I think these basic things at least should be taken care of before planning even the first or the minute test of the procedures.
Yes. So I think a pre-operative assessment can be done as simple. A pulmonologist can do a good 6-minute walk test, a PFT if present, then a operating system which should be fair enough. I don't want every peripheral center to have a 4K system. So a normal HD system can work. Then VATS instruments, which is very important, but you may not have the best of the sets like Scanlan, which cost around 1 crore. You can have Indian sets like SM Digital and all those, which cost 1.5 lakhs. You have these maybe ambuscopes for bronchoscopies, intraoperative. Then most essential, I guess, is to have an open set, vascular clamps ready so that you can tide over the situation. And do you think blood bank is an important component?
Yeah, totally. I was going to say that you should have a backup open surgery option that is much needed, because कौन सा case कब खराब हो जाएगा and you might need to open, you never know. And obviously you need to have the other things like a blood bank, which are anyway needed for any major procedure. I think those sets of things should be always be taken care of.
And maybe closed suction systems for these decortications, because they make a lot of difference. We have seen in our practice, we have around 20 or 30 of them. So very important. So not that much, but at least plurivac, OSAs or medallas, basic equipment should be present.
I totally agree with you. One instrument we have with us before we started our VATS unit, and that I think it is a must. At least I won't say the wall suction and all that may be too costly. We are discussing low cost VATS, but yes, definitely one instrument you need to have, because you are not going to do cases every day initially. So maybe when you have,
you can use them.
Yeah, slowly you can develop. Very right.
Dr. Manju, you are called to operate upon a case of stage 2 decortication in Nanded. What is the minimum requirement you will tell Dr. Bharat that this should be there, so I am coming?
So the first thing is I want the anesthetist to be familiar with the OT.
Yes.
Because our game
and should be trained in some thoracic surgical knowledge.
Yes, sir. Because now all 2-tier cities are running successful cardiac programs.
CTVs,
Most of the centers.
Yes.
So we will get a cardiac anesthetist So that is a basic requirement, because what happens is you will see that they are suffering with the tube. You are already inside the chest and they are suffering with the tube. They're not able to ventilate this lung or that lung. So
That's a
that is
bad
a
day.
major problem. So I asked them, please ensure that you have the anesthetist in the OT who understands things, who has what he wants. That's one of the important things. We have a
Yes.
detailed discussion with the anesthetist. That is the first and most primary. Because
Yes.
if I don't do a procedure, patient will live. But if something goes wrong, we may lose the patient. So that's one of the
Yes.
most primary
Definitely.
aspects for me. And then I have a set of VATS instruments, as you said, the cheaper ones where we can use it. And then I asked them to get at least cautery and cautery and hook cautery and monopolar, so that we can use them. Other things are generally open set of instruments, which I usually tell them to have. Rest, I think we can manage mostly with the things we have itself. And if there's a bulectomy or a lobectomy, I ensure that we have the correct staplers for that.
And guns. Okay. Dr. Yogesh, now my next question is, if would you like to segregate your patient based on the pathology? What pathology you want to get operated in a big corporate tertiary care thoracic setup, and what pathologies you want to get operated maybe in a peripheral center with less acute peripheral center, if I may say so.
Yes, sir. Case selection is very important, as
Very important.
if it's a simple case of pleural procedures, like if I have to do a simple, there is an air leak or pneumothorax, or there is a hemothorax, a loculated collection. If we need a simple decortication, which is not complicated by a prior, as Dr. Manjunath was there, that if there's a prior pleurodesis and if it's a complicated empyema, and the patient is at extremes of ages, then definitely, and with a lot of comorbidities, if the patient has a raised serum creatinine levels or a prior history of some cardiac issues, then definitely if the patient has a lot of comorbidities, I will not like to do that cases in a smaller setup. But if these are young patients and simple pleural procedures or simple bulectomy kind of procedures, they can be tried at a smaller center. So definitely case selection is important, and that is again a way to reduce the cost. We just cannot, all one size fits in all does not happen here. We have to do all the investigations, whether it is pre-op investigations or operative requirements or post-op care. It will differ from case to case.
Great. Dr. Bharat, the same question to you.
Yeah, I mean, currently what now we are, I will share my practical experience. Dr. Manjunath here is there, who is our surgeon most of the times. I think empymas are the best ones, the 1 or 2 grade to start with. They are relatively simple, and the return of the case, so the patient goes home very well. So the overall holistic, the vibe is very positive. Anytime when you start a new procedure, the few cases initially should be done good. Now, as he was also saying that air leak in a simple pneumothorax, maybe a bulectomy, recurrence of a pneumothorax, it can be done. And slowly the other ones, which massive hemoptysis, maybe a lobectomy, that I think should be done very cautiously. And after certain experience, when your team and the surgeon all are in sync, then probably you can.
Yes. Dr. Himani, if as we discuss all the cases the previous evening, which we are going to do the next day, is there any difference in your strategy if if we tell you that yes, tomorrow we are doing this by VATS and this by open surgery, any difference of your strategies, anesthetic point of view?
So, basic preoperative evaluation will be mostly the same.
Same.
Because any VATS can get converted to open or anything like that. So
Yes.
that there is no change in that. That will remain the same. But for open, mostly the pain management thing changes a lot. Because if it is obviously an open case, we'll obviously put an epidural before induction or maybe after induction. That is most of the time it is the main thing.
Or you give lot of blocks these days also.
Blocks, yeah, that we mostly give for VATS.
Yeah.
Trying to avoid epidurals, but basically mainly this thing. Rest all remains mostly the same, sir.
Mostly the same.
And one thing I wanted to add for cost cutting from our side, that we can use DLTs which are Indian made.
Yes, yes.
Like we are using
Romsons and-
Romsons in our center. This is half the cost of Potex and Roche and all those things. And
very important.
even the epidurals, we can use Indian Romsons similarly. So these things also, cut the cost.
Cut the cost. So definitely, I'll tell what we do in Vedanta. I'll just tell in 5 minutes, next 5 minutes, what we do in Vedanta. The first cost cutting measure is that you have to convince your administration, if you cut the cost, the number of thoracic surgery will increase. Because thoracic surgery is a low cost surgery. It's a lower socioeconomic status, which has to come to get these empymas and all those stuff done. So you convince your administration that you create lot of beds where you have a combination of single rooms, twin sharing rooms, multi-sharing wards. That is the most important point in getting the cost down. The second point, as Himani already has told, that we use lot of this Indian stuff these days because by our Prime Minister's initiative of Make in India, lot of Indian companies are also coming up with good stuff which can be used for cutting the cost. The third is the Robin Hood approach. Take from the rich, give to the poor. So if you have, like we have in Medanta, 100 to 150 cases of thoracic surgery happening every month, you have a big repository of equipment which you can use in these patients. So my third year PG sleeps on at least 500 staplers inside the bed box he has, and hundreds of guns, hundreds of medulla reusable apparatus. That is the third way of bringing down the cost. The fourth way of bringing down the cost is to do a very good surgery, as Dr. Manjunath told. What you do good in surgery will be reflected in the post-operative period. If you mess up your surgery, you cause lot of bleeding, lot of air leak. You may have to shift your patient to the ICU, which may increase the cost. And last thing is you have to create some measure by which you can discharge these patients with chest tubes also earlier to outside the hospital. How we do it is that Medanta is surrounded by lots of these lodges which are equipped with having these sisters who can at least tell you the saturation of your patient, the pulse rate of your patient. They can watch your patient. They can do a video call with the operating surgeon, or we have created a big pool of coordinators who are specially trained sisters in thoracic surgery who do a video call with these patients. Our physiotherapist does a call with these patients once a day. These patients are discharged on second or third post-operative day. They are kept in these lodges. They are told to follow up with the treating physician or the treating surgeon, maybe alternate day. Every day, 1 or 2 calls are made by our coordinators to these patients. And by this measure, we are able to reduce the cost to a very low factor, even in a big setup like Medanta, like Dr. Bharat was telling that we are able to do a decortication for stage 3 in 1.5 lakh. I assure you that we are doing a stage 3 empyema in 2.5 lakh and a lobectomy in 3 lakh rupees. The way we have brought down the cost is just by doing these measures. One of the very important point I want to state in the end is safety of the patient is the most important. We are reducing the cost. We are not going to compromise on the quality of the care. We are not going to compromise on the safety of the patients. If these two factors are being taken care of, only then a person should be talking about reducing the cost of these surgeries. I think, Dr. Manju, you agree with me? I think we have lost Manju.
Yes, sir. Yes, I
Okay.
totally agree with that. Sir, the cost may be one thing. The patient safety is of the utmost importance.
Is the most important thing. Thing. So I need one of your concluding remarks. We had a wonderful discussion. Just a small concluding remark from your side, Dr. Manjunath.
Sir, as I said, when we think of cost, that should not be the main concern in any patient or any surgery. We can somehow reduce the cost if we want, but main thing is patient safety should be that of utmost importance, and patient
100%.
getting back to a normal quality of life should be the goal, not just discharging him.
Yes.
Yes.
Dr. Bharat, your concluding remarks, sir.
Absolutely. Safety is very important. Choose your cases wisely. Have a proper team, especially to manage some post-op complications which you might acquire. And it is a multidisciplinary approach. Definitely, percolating these specialities into smaller towns is good, but you have to be very wise and knowing what not to do rather than what to do.
Great advice, sir. Dr. Dinesh, your concluding remarks.
I absolutely agree with all the panelists. And of course, the multidisciplinary approach is the way forward. Looking at the things where we can do and what we cannot do and what we should not do. That is very important. And keeping all this in mind, safety of the patient definitely
Is the utmost.
and also safety for us.
Great. Dr. Yogesh.
Yes, cost cutting should be at all levels. That is whether it is the pre-anesthetic level or the anesthesia level or the surgery level and the post-operative level. As you said, prior discharge and then better coordinating with them and not going for all the investigations. But apart from this, as you said and everyone said, safety is of the most important concern. We should not compromise with the safety of the patient. If it is being compromised, cost should be secondary.
Secondary. Definitely. Dr. Himani, the anesthetist should speak.
So, of course, the safety, we should not compromise on that. Sterility, we should not compromise on that. Basic blood bank and ICU backup, definitely anesthetists and trained technicians, trained nurses, all that backup should be there. And then I think we should think about cutting the cost. First, all this basic backup
Definitely.
should be there. Yes.
Definitely. So it takes a village to do a thoracic surgery. It takes a village to do a bad surgery. I just want to tell a good bad surgery is very good. Even a good open surgery is pertinent
Is as good, yeah.
in the scenarios. And cost cutting should always be a second level in the mind of the physician and the surgeon. The safety and reaching the home safely, sitting with their family, having dinner, as Manjunath has told, are the most important things. So beautiful discussion. Thanks, CCI, for putting this very pertinent topic to the public, to the listeners, to the pulmonologists, young surgeons, everybody involved. Thank you and have a very nice day. Have a very nice sleep. अपना बहुत बहुत ख्याल रखिएगा. Namaskar.
Thank you, sir. Thank you, CCI.